You'll hear a bit about a wonderful learning collaborative that we have. And then, so first project will be shared access to the patient portal with the affiliated learning collaborative. And then we have a second project supporting care partners in dementia care, and another project, OurNotes for care partners. So you'll learn more about all of those. And then there should be plenty of time for Q&A and discussion. In terms of housekeeping, we're recording the session. We will send out the link afterwards, and it will be posted on our YouTube channel as well. So feel free to share that with others. You are all muted. If you want to ask questions, click on where it says Q&A, and you will see that there are already some comments in there. Feel free to share comments and questions in there. I will respond if there are questions that I can just quickly respond to in the Q&A box. Otherwise, I will save questions to pose to the presenters afterwards. And if you have any technical difficulties with anything, also please put something in the Q&A, and my colleague Isabel will help you out with that. Next slide, please. So the 3 projects we'll be talking about, these are all of our project partners. As you can see, there are many, plus the funders of the project. So you'll see some of these names again later in the presentation, but just a big thank you to all of our project partners and funders, and you'll be hearing more about them as we go along. Next slide, please. And I'm thrilled to introduce our 3 speakers. Kate DeRoche, who is the Executive Director of OpenNotes at Beth Israel Deaconess Medical Center and an Associate Professor at Harvard Medical School. Jean Ross, who is the CEO and co-founder of Primary Record and a wonderful active member of our Shared Access Learning Collaborative. And Jennifer Wolf, the Eugene and Mildred Lippitz Professor of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. So I will pass it over to Jennifer with the next slide. Thank you.
Thanks, Deb. So I am happy to kick us off in terms of background with this wonderful quote by Susan McDaniel: "Without considering the patient in his or her family context, inadvertently eliminates both a wider understanding of illness and a broader range of solutions, including family members, means the clinician has enlisted his or her most potent allies." And this is really the underpinning of all of this work, we've just recognized the important role that families play in care delivery for across the lifespan, and especially in the context of chronic and serious illness. Next slide. And I just wanted to share this schematic, which reflects this the status quo graphically, and it shows the what complex care looks like. This is an 80-day period for a person who was experiencing an acute episode involving 12 clinicians, showing more than 60 contacts, 5 procedures, and 11 office visits with all of the various health system stakeholders. And in the perspective, there's a mention of the patient's wife, who's referred to as the caregiver, but you'll see that she's notably absent in this schematic. And this really reflects the status quo of where we are in care delivery, where families and family caregivers are just largely invisible and are a shadow workforce. Next slide. And just to acknowledge, there are a number of implementation challenges for engaging families. Reimbursement clinicians fail to provide incentives to compensate clinicians for their time and effort to identify, engage, and support family. There's a prevailing emphasis on patient autonomy and privacy, and that often can be a barrier to providing information to families that's appropriate and beneficial when they're involved in coordinating care within the system, as well as providing hands-on care or overseeing care at home. And then the patient-oriented information systems largely fail to capture structured information about the identity and the role of involved family members and friends. And so all of these challenges really sort of set the stage perfectly for shared or proxy portal access, where patients and families are able to make these decisions about who patients want to involve in their care. Next slide. And I just want to acknowledge that there is a growing body of evidence in the scientific literature that document that patients across the lifespan prefer to have family have access to their electronic health information, that shared access functionality is widely available and made available through electronic medical record vendors, and has been implemented by integrated care delivery systems. but that uptake has been limited. Importantly, we have undertaken a number of demonstrations and randomized trials showing that facilitating shared access benefits patients and their care partners and their perceived experiences of care in the quality of communication with clinicians, patients' confidence in managing care, and for care partners who are engaged in using the portal, their illness understanding and reduced symptoms of anxiety. So there's a number of reasons to believe that this is a beneficial strategy that merits attention. And I'm going to turn it over now to Kate.
Thanks, Jennifer, for that great background information. Now we're going to move into talking about some of the work that Jennifer and Deb and Jean and Isabel and I have all been involved in over the last few years that's really focused on trying to overcome some of those implementation challenges that Jennifer referenced. And we think of the work as sort of going from this in a pyramid structure where the base of the pyramid, the biggest, the solid underpinning of the whole of all of the work is focused around getting care partners onto patient portals using shared access. Once you've gotten there and you have care partners signed up, there are a lot of other things that can be done to sort of loop the care partner in more tightly to the care team, including more effective use of existing functions, generating content, having care partners and patients co-generate content for the record, all the way to these more aspirational goals focused on AI-enabled feedback for education and resources and feedback loops for clinical care. So we're going to talk about some projects that we have done sort of in each of these areas. And I'm going to start with engaging family care partners through shared access to the electronic health record. So like many of our projects, this one has quite a few partners, including our clinical partners, Providence, the University of Utah Health, and University of Rochester Medical Center. It's funded by the John A. Hartford Foundation and the Cambia Foundation. And this project actually started pre-COVID. Jennifer and I started the planning phase in the pre-COVID times. So this has carried us through many years. And it's predicated on the idea that shared access to the patient portal allows patients to identify who they want to have involved in their care in a structured way. It legitimizes care partner involvement. It provides greater information transparency for both care partners, patients, and clinicians. It allows clinicians to know who's involved in the health system interactions, so they're not guessing about, who provided this information through the portal, who wrote this message to me. And then it facilitates really secure bidirectional information exchange between clinicians and care partners. This is a collaboration, again, between OpenNotes and Johns Hopkins, again, with I've mentioned the clinical partner sites. And the goal of it was really to increase registration and use of shared access to the patient portal for older adults. So in the pre-COVID times, we started the planning phase of this grant. And we used a co-design process in which we really tried to first understand the issues that people were facing with this problem. So understanding the issues faced by patients, by care partners, by clinicians, staff, IT, the IT staff in healthcare organizations. We really did sort of a full review. Sorry about the barking dog. A full review of the problem, figuring out the problem, and then ideating and generating ideas. And this was about an 18-month planning grant where at the end we had created a prototype, and then we've recently finished the testing phase of this. And we co-designed a workflow with the patients, with the care partners, and with the staff and clinicians in the practices. And this is kind of the idealized workflow. Patients at home might get a brochure or an appointment reminder call that says, hey, think about signing up for the patient portal. Then they're touched again in the waiting room with posters and brochures. The front desk could be a place for information about shared access. And then there's during the rooming process, the clinician visit, and at the checkout. These are all places where a patient and a care partner could get information about using shared access to the patient portal. Now, because we co-designed this with our sites, not every site did it the same way. Some used the front desk option, some used a checkout option. Everyone used the poster and the brochure. And this is through our co-design process what we came up with for messaging. So here we were trying to create eye-catching, easy to understand materials that would help patients and care partners have conversations about shared access with the staff and the clinicians in the practice. So using our co-design process that involved patients, care partners, all of the stakeholders, we came up with this tagline of people remember less than half of what their doctors say. And this is a poster that was that you can find at the University of Utah Health in their geriatrics practice. And it just gives some basic information and a website about where they can go to find out more information. We also had a brochure. It had that same front with the people remember less than half. And then it has more information. If you think about this as a folded brochure, when you open it up on the inside, it gives you information about how to set it up, what the benefits are, and kind of what to do next. So these materials were available to patients and care partners at various kind of stages throughout a clinical visit. We also had clinician and staff-facing materials. In our planning process, we discovered, or we learned that there were obstacles in place for clinicians and staff. And they were primarily, we don't know how to do this. We can't remember. It happens so infrequently that I'm relearning it every time. So we had talking points for discussions. We had how-to tip sheets for staff. We had smart phrases that allowed the clinicians to embed information about shared access right into the after visit summary. And then we had web page FAQs. We worked with the marketing and communications people and the IT staff to make sure that the web pages gave accurate and easy to understand information about how to sign up. So I'm going to turn it over to Jennifer, and she is going to talk some about what we learned through this process.
Great, thanks, Kate. So,
oh, sorry, Jennifer, I just clicked the wrong thing.
Yeah, so along the way, we went through a process with all of the sites where each of this to try to align the metrics, the reporting metrics, so that we could understand how the rollout of the intervention affected registration and use of the patient portal. And so we worked with the informatics teams, and we had regular monthly reporting to understand how, the effect on registration and use, and to look across over time and then across the sites. This was incredibly helpful in terms of really understanding how the rollout was going, and then also in some ways motivating the sites because we were working across more than one site. When one was when the uptake was more impactful at one site, the others were sort of were spurred on. Next slide. I just want to acknowledge that we had a fairly multidimensional evaluation approach. It was a mixed methods, and there are two papers that are now under review. One that evaluated more qualitative elements of the rollout in terms of the acceptability and perceptions of the clinicians and the clinic staff, in terms of their experience with the intervention and the materials, the effects on operations and use of the portal. And a paper that is led by Vadim Buchanan is under review. We also, I want to acknowledge, had, as Kate mentioned, extensive stakeholder outreach, and a paper that describes the development of the materials is out in this month's JMIR. And the next slide shows that we did track, our primary endpoint was quantitative effects on portal registration. This is showing what the monthly run charts look like and for 4 of the 5 sites. So one of the clinics that had a geriatrics focus is not listed here. And I just want to show, make 3 points. One is that the uptake was the greatest at the geriatrics clinic, which is not presented here, and it really reflects the importance of context, and that both the greater needs of the population served by geriatrics clinics, as well as the greater experience of the staff, most definitely has an effect in increasing the registration and use of shared portal access. The second is that, as you see here, we observed benefits in increasing registration of shared portal access functionality, but they're relatively small in month-over-month effects, and suggests that the intervention had a constructive, beneficial effect on our primary outcome, but it was not a silver bullet. And then third, not presented here, but in the paper that's under review, we found that among care partners who are registered for the portal, use of the portal functionality was much greater than for the patients who are using than the patient registration, and care partner use of the portal functionality increased fairly dramatically over the period for all of the functions except for messaging, where care partner messaging remained low. And this, I think, suggests that care partners find benefit from use of the portal, and that it may alleviate clinician concerns about the potential impacts on messaging volume. And then I'm going to turn it over now to Jean.
Yes, so I was very fortunate to find the shared access team. I am a nurse by training and had left critical care to run a care coordination company in my community. That then kind of showed me a problem of how hard it is for families to kind of engage in that story of that older patient in the community. So I actually had spent a lot of time, doing this. So the purpose of the shared access was helping bring stakeholders that were trying to figure out, like what could be the best practices, what are the challenges, and what are and some of the things that the team was coming up with for us to give insights to. So we met quarterly starting in July of 2022. It's such a fun group. We actually got together a couple of weeks ago, and it was just, we all hopped on just to like see each other because we were kind of hashing things out. But it has a great representation from healthcare professionals like me, as well as technology, people in the technology space. But probably my favorite are definitely the patients, and then those that are kind of researching this space, as well as the advocates on there. So just a great representation of the different stakeholders that are looking at this idea of shared access and the impact it could have on our aging communities. And it was super, so one of the things when we were meeting, the team asked if we could run a secret shopping exercise. And so each of us were challenged to go figure out how to share access with our family members. And so there was a survey that we would fill out in our experience. And if you had done it and could remember some of the things, you're welcome to completely to fill it out and give insights. Because something that, you know, this project, a lot of the partners that we worked with were definitely with the MyChart, you know, and Epic community, recognizing that a lot of families interact with a lot of different portals. So this was a great survey that allowed us and the team to kind of get a plethora of the different portals that families are facing and really have a lot of great takeaways on how there is not one universal way families can share access and some of the problems that families are facing and how hard it can be to engage. So the great thing of, you know, that came out of this was just to get the true experience. I think it's one thing to talk about this problem, but to go challenge people in your system to go see the barriers themselves of what it's like to try to get access to their family's portal is phenomenal. And it's something that I actually learned, if we go to the next slide, and kind of, you know, the 5 successful attempts. The piece here too was there was some people that were quickly able to, and then there was folks that how they mapped over time. I know for my own story, it took months after requesting access. So it was just definitely very varied and the experience and trying to help our those on the shared access team to really help get the points of this research hammered out. And so the barriers, it was great to kind of get the insights from the survey as well as the ongoing conversation in the shared access collaborative. And so the group did a great job of kind of taking the stories of everyone that was engaging with the project and the things that the team was learning and implementing in the different sites. So what we learned from the families and from the shared access collaborative is, you know, there's the barriers around technology. It's not always clear in that portal where and if they can do a shared access request or proxy access right there electronically. And if they can, the multiple clicks that it can take or that it's buried somewhere in a menu, as well as there is this, the verification steps are very arduous from families that recognizing in the technology space, the harder it gets, the more likely the family is just going to continue to log in as their family member. And we know that there's huge benefits if we can get that person to make an account. And then there are the barriers around forms. We heard stories from the folks on the Shared Access Collaborative on, well, can you come by the office? And a daughter saying, no, I live 4 states away, right? So there's these policies that these healthcare systems and provider offices are putting in place that are making it very difficult to share that access. And that often requires some kind of form or being in person, and recognizing in today's world of how spread out families are, how that does present a barrier to sharing access. And then there is the access itself. I know in my own story of going through this process there, I was faced with staff members at a front office that didn't understand my right as a wife to ask requests for my husband's patient portal, that, you know, our genuine interest in sharing. She didn't think that was possible as adults. She thought it was more of a pediatric kid thing. So, you know, it was interesting to see and hear from the different shared access folks around what challenges they face. So everything from, you know, this is only available Monday through Friday. You know, that's not really how family emergencies can sometimes happen. You know, this playing a phone tag, trying to find that right person to request access. And of course, some of the incorrect information on the website. We did hear that from some of the different participants that, you know, there'd be links on the website, but they would go click and it would kind of lead to a dead end. So just getting that user, like end user experience, that family experience, and really laying it out just really brought to life the barriers that are really the challenges that families are facing today. And so if you represent an organization, I definitely just, I'm so glad you're here today so you can understand some of the challenges that your patients and families are experiencing, and really thinking through, if we're talking about patient and family engagement, how are you going to remove these barriers to really to harness the benefits of that? And I will share, so I am a critical care nurse, and then went into my community, and then I'm married to an emergency room physician. We definitely had a good time making this secret shopper video that we ended up putting online, and it's probably one of our favorite videos. And our sons are completely mortified that we're on YouTube. But what we did is we recorded live, and it took 8 minutes. And what's funny is I thought I had a one up on my husband, because I actually, when I was running my care coordination, I knew that our portal at the time was allowing me to help families share access. We were on a Cerner instance at our academic hospital. And I thought I had the one up on him. What I did not realize is that our health system had changed the policy. And so when I pulled up our portal thinking I was going to beat him to it to figure it out, I discovered that they no longer allowed an electronic way for me to share a code to grant him quickly access. And so then we were both lost. So I will say it's like an 8-minute video that then resulted in the fact that he had to find, and buried in the FAQs was that we had to go to our front office staff and make this request. And so we laughed because it was like 6:40 p.m. on a Tuesday, which is when most families start discussing the coordination of care. And we gave up. I will share 3 months later, he was having a primary care appointment, and I was like, oh, let me just go. Let's figure this out. We got to figure this out. And that was when I was faced with the front office, who thought I was crazy, and that I wanted access to my husband. She kind of looked at me like I was crazy, that she's like, only kids and parents do that. And I asked her, well, what do you do with a daughter that might have a dad with dementia? And she goes, oh, I just tell her to log in like him. And I was like, okay, you don't know who I am, but I am actually part of this group called OpenNotes, and that is not the right thing. So we got our supervisor involved. And I had to urge them to go to the next screen. They didn't even think there was an option to share adults. And when she does, she goes, oh, look at that, I can share access. So the training of staff is so instrumental, but I also have to encourage systems. Why are we putting on our poor primary care offices? They are already overburdened with so many requests from patients. So really taking a step back at your organizational level to understand the experience and the barriers that your families are facing. And if a nurse and an ER doctor can't figure it out, that might be the way to solution your own organization is, can your own employees learn how to share access with their family members? So, all right, I could tell stories all day here. So next slide. And so I was very honored to kind of review these toolkits, because I am in both worlds. I work closely with family caregivers. I'm trying to knock down and really try to help create systems that families can have that one place for their information. So speak the caregiver language and the importance of sharing access. But also in the other world, we need to educate our providers and our clinicians and our systems on, why shared access matters. So the wonderful team at OpenNotes have created these toolkits. I actually am a chairwoman for our Patient, Family, and Advisory Council at a health network. I've brought this to our PFAC because I promise you this challenge is being faced by your families, and they are solutioning and around it. And is it the safest thing or most secure thing? So these two toolkits are great for you to review and kind of get both perspectives, and they are filled with great ideas and approaches on educating and really moving the needle on getting our families to understand the importance of their own account and sharing in, as well as for your clinicians to understand that this does not create more work. It only increases that engagement of that family and empowers them with the information that they need to take care of each other. And then our learning collaborative has just been super inspiring to be a part of. So I don't know how this team does all the things that it does. I only get to join every other month and give my insights and join some really fun people. But they have also brought to us ideas on, what are the other stakeholders around this, and how can we really help drive this belief, the quote that Jennifer started with is really what moves this entire collaborative forward. This belief that when we engage our families, that's really the next stage that we need to be doing in our country to really arrive at the health outcomes that we need. So, we've submitted recommendations for updates to the national strategy, because it's just access to data is not something that we think about when we're thinking about caregiving. And so really putting in forefront of making sure our caregivers are included. We've also been working, there's an amazing patient engagement playbook But our team is re-looking at that through the lens of the experiences that we have found through this collaborative on how difficult and all the barriers it took to get access. So we are making recommendations to the ONC and and nobody can remember their current, the ASTP, it's like Support Assistant Secretary of Technology. I don't know. I'm going to butcher that. And then we continue to develop tools for the learning collaborative members to approach health systems. And I think that's where the change happens. Everyone on this call has the power within them to bring this to their health system. Because really our health systems are so overwhelmed with a lot of things. But if we can kind of demand something that's going to help the whole system by being included and get information to where it needs to get, I think we only make improvements by bringing these things. So if you ever have interest in joining our learning collaborative, we're a fun group. So definitely reach out. Our next meeting is February 4th. So thank you.
Thanks so much, Jean. That was terrific. I will echo Jean's call. The Learning Collaborative is open to anyone who wants to join. We are a really fun group. If you're interested in joining, just get in touch with Deb and she'll put you on the invite list. Quickly, as a final step on this shared access project, we're in the final year of the project, and we're taking what we've learned to try to think, and then thinking through, based on what we know, what did we learn from the evaluation? What have we learned from Secret Shopper? Where should we be putting our energy? So we're focusing on in 5 different areas. One is capacity building. So Jean and the Shared Access Learning Collaborative is an example of that. What can we do together that puts materials in people's hands so they can go back to their organizations to say, here's something we should focus on. So capacity building. We have a group that actually starting in December to start to think about how do we work with vendors to improve functionalities for patients, including things like granular privacy controls and better sort of wayfinding through the portal to make it easier to sign up. So we're also thinking about policy and measurement. So where can encouraging patients to sign up for shared access, where can that kind of slide into things organizations are already doing? And maybe that's around the age-friendly health system movement or the new dementia guide models. How can shared access become part of the 4M, measuring the 4Ms, what matters to patients, what matters to older patients. And then finally, we're thinking about, although we have not settled on a firm strategy around organizational change. One of the things we heard loud and clear from our project and from the Secret Shopper project is that organizations, well-meaning organizations, put barriers in place primarily around compliance and concerns about data privacy, but these barriers can make it hard for families to get the information that they need. So thinking through those organizational steps. So we're going to move on to a new project now. Then I'm going to turn back over to Jennifer, and we're going to go back to our pyramid for Jennifer to start off talking about the next project.
Thanks, Kate. So the next project is focusing specifically on dementia care, which Jean mentioned earlier in her remarks, and looking at, you'll turn to the next slide. So this is a project that also has multiple partners, which are listed here, including University of Colorado, and Hillary Lum is a partner. Next slide. And I think this is, we can continue. This is a project that's funded by the National Institute on Aging, and it has 2 aims. And it's really focused on recognizing, we know very little about how people with dementia currently navigate electronic health system demands. There's been very limited attention to this. And so the first part of this project is just understanding the current environmental landscape of how are older adults with dementia navigating the electronic care delivery landscape using the patient portal. And then secondly, are there opportunities to innovate to provide technology-supported interventions to benefit people with dementia as well as their family care partners. And so as part of the first aim, we have undertaken a number of environmental scoping reviews, and used, we've done a survey-based analyses, and it's clear for older adults with dementia that care partners are more often using the patient portal. But we also decided to work within our own health system to understand exactly how are older adults navigating the patient portal. And so we did a web poll, a descriptive paper, and we compared 3,000 older adults who had a dementia diagnosis, shown in purple, with about 46,000 older adults who did not have a dementia diagnosis, shown in white. And surprisingly, what we found was that having an active login, having an active account as defined by logging in was virtually the same, regardless of whether older adults had a dementia diagnosis. And, we found this incredibly surprising. We found that older adults with a dementia diagnosis were about 3 times more likely to have a registered care partner for the portal, but that rates were relatively low in both groups. And so it was only about 1 in 10 older adults with a dementia diagnosis who had a registered care partner. On the next slide, we show what happened around the time of dementia diagnosis. And we looked at 3 metrics, looking at messaging, shown in orange, numbers of login sessions, shown in gray, and a ratio of portal sessions to medical encounters, shown in blue. And for all 3 measures, we found significantly more portal activity after a dementia diagnosis as compared to the 12 months before. And so this suggests that that it's really not a good idea, that some of the lack of attention to this population is really a mistake by care delivery systems, that older adults with dementia and their families are using the portal, and that they find use in the portal as evidenced by greater use after a diagnosis. In a companion paper on the next slide, we manually examined secure message threads, and we found that 2/3 of the messages sent from accounts of older adults with dementia were authored by a care partner, and that 95% used the patient's identity credentials. And this really gets to some of the issues that Jean was talking about, around the challenges in accessing their own identity credentials, and also some of the, what the staff may be saying. The staff may just not have the education about how to navigate the registration process. So in the next slide, I want to just briefly share a innovation that we undertook through the same project with our partner at the University of Colorado. This was building on an innovation of OurNotes that has been led by folks at OpenNotes, where patients are emailed in advance of a medical visit through the portal and asked about what they would like to talk with the clinician about, and what concerns they have for the visit. And at UC Health, we had the opportunity to adapt this OurNotes approach, and to ask who was completing the OurNotes survey in the geriatrics clinic. And so so we did this adapted OurNotes question. This innovation was implemented in May of 2022, and it has been running ever since. And this is just showing a screenshot for those of this question, whether you're the patient completing the form by yourself, whether you're the patient, someone's helping you, or whether you are not the patient, and if so, who are you? And so in October of 2023, we did a chart review, and Hillary Lum led this work. It's published in the Journal of General Internal Medicine. For anyone who wants to read more, and we'd be happy to share the paper. We did this chart review over a 1-week period to really understand how are patients using this adapted OurNotes question. And what we found was that more than 1 in 4 patients completed this pre-visit questionnaire. And among those in the geriatrics clinics, about 1 in 5 were identified as a care partner completing the questionnaire on behalf of the patient. These care partners were more likely to be helping the patients who had a non-patient respondent or a care partner were more likely, not surprisingly, to have a diagnosis of cognitive impairment. They were more likely to be older, and the responses about the concerns for the visit were different. The care partners were more likely to bring up issues around symptoms, the need for community resources, and concerns about dementia. And so all of this is really, I think, collectively interesting and important, and sort of speaking to the fact that care partners are involved in navigating the care delivery system, and that it's possible to use existing technologies to find them. And that when they are involved, they do bring up different issues that may have a bearing on the clinical encounter. And this is consistent with what we've seen in other work, but not using scalable technologies. So I think it's very exciting. I'm going to turn it back over to Kate, who is going to talk about another project that builds on this OurNotes work.
Thanks, Jennifer. All right, this is our third and final project we're going to talk about today. And it is in this third layer of the pyramid, so patient and care partner generated content. It builds on the adapted OurNotes project that Jennifer just talked about. This project is part of so this is OurNotes for care partners. And what we're trying to do here is we're trying to identify care partner needs in a clinical setting. So it's a little different from the earlier work in which we were trying to kind of identify the care partners of patients. In this project, which is a collaboration between, again, OpenNotes, Hopkins, and a new collaborator, Archangels, we were trying to identify care partners. They could either be a care partner of a patient coming in for a visit, or the patient could be a care partner to someone else. So recognizing the strain that being a care partner can sometimes place on a family member, we were trying to see, is a clinical setting an appropriate place to try to identify and connect people to services. Our partners in this project we had 3 primary care practices at Beth Israel Lahey Health, and then 2 practices at Michigan Medicine. It had an IT component and an in-person component, which I will talk about next. The goals of this project the goal of the intervention is to identify the care partner, set the agenda for the upcoming visit, and provide care partner support. And we did that. So this is a diagram sort of how the project worked. So 3 days before a clinic visit, a patient gets an email inviting them to log on to the patient portal and complete a questionnaire. It asks them who is filling out the questionnaire. Are you the patient or someone else? It engages care partners by asking them, patients and care partners by asking them how they've been since their last visit and what are the top 2 things they want to talk about today. Everyone is then asked whether they're a care partner. So I'll take just a second to note, these are not the actual questions, but the questions won't fit in these boxes. So these are just paraphrasing the questions. So for people who say they are a caregiver, either they are the caregiver of the patient, or the patient is a care partner for someone else, they get a link to Archangel's Caregiver Intensity Index. I'll show you what that looks like in a second. They can go through this very quick, simple index to identify sort of what's going well for them, what's not going well. They get a color and a score, which they can then add into the questionnaire, and that information is then available to the clinician. And they also have tailored community and issue-specific resources that are available to care partners at the Caregiver Intensity Index website. So this is a screenshot of what you would see if you scanned this QR code. This is available to anyone. You can scan the QR code, go on and take the index if you know, yourself. It takes about 2 minutes, 2 to 3 minutes to complete. It's very nice looking, and it's pretty easy to get through. And then when you complete it, you come to this page, which gives you, here's your score. So this was my score at the time when I took it. I was in the yellow, so I said sort of moderate caregiver intensity. And it also gives me information on what's going well for me, where are the stressors, and then the community resources. So we implemented this pre-visit questionnaire in our 5 practices, along with in-practice flyers and posters and care cards that clinicians could hand out, along with support for the clinicians and staff, with kind of talking points about how to have these conversations with patients if patients brought it up. We have completed the intervention period, and these are the results for Beth Israel, for our Beth Israeli Health primary care patients. Almost 20,000 patients received the questionnaire. 45% of them completed it at least once. So we did better in our response rate than in my wildest dreams. I was really surprised by how many people filled it out. Among those filling it out, almost 20%, or almost 1 in 5, said they had care partner responsibilities. We had 620 individual patients who completed the CII. So most often they went to the CII through the questionnaire link. We were able to track that through specific QR codes for the questionnaire, the in-office materials. For the most part, people were in the yellow, so they had some kind of a moderate level of intensity. And the most often cited drivers were feeling like they had no time and feeling stressed out and depressed. The clinicians and staff reported that OurNotes for Care Partners was simple to implement. They felt more able to ask patients about care partner responsibilities because they had a resource to offer. This came up early in our discussions about what would it take to implement this, with clinicians and staff saying, yes, we know this is an issue, but we have nothing to offer our patients, so we don't want to ask about it. So having this resource really empowered them to ask. They said that patients generally appreciated being asked. They were worried that they would feel that patients would be irritated about being, asked to fill out another questionnaire. But for the most part, patients were very positive about it. In fact, the biggest challenge that they had was remembering how to look up questionnaire answers in Epic. That we had to do quite a bit of training about that. And then we found also that there was very little use of the SMART phrase that would drop information about the CII into the after visit summary. So there's going to be a lot more to come on this. The first paper is under review that describes the model. The second, third, and fourth papers are in process. So a lot more to come there. And then finally, before we turn to questions, I just want to note that, since the explosion of generative AI, there are, I think, opportunities both on the clinician side and the patient side and the care partner side to use generative AI to help patients and to help patients and care partners understand their information, but also on the health system side to use things like large language models to identify when a message is being written by a care partner versus a patient, to use large language models to identify key care partner issues and send resources and information. So there's a lot of opportunity here. Our work in this area is small but growing, and we'll have more to offer on that in the coming months. Finally, if you want to find out, oops, sorry, I went too far. If you want to find out more about any of these projects, access the toolkits or more about our partners, here's the Coalition for Care Partners website, and you can scan this QR code to get there. And we're going to stop now for questions. We have about 10 minutes. I'm going to stop sharing and turn things back over to Deb.
So I don't know if you want to reshare, because the first question refers to one of the early slides.
Oh, okay.
It might make one of the very first few slides where you talk about some misalignments.
Okay, this is, now you've challenged me.
Sorry.
I have to find, okay, I got the slides. And so one of the first slides.
So keep going. The first, right there. So one question in terms of the misaligned reimbursement, the question was, if providers are salaried, is there still a misalignment?
Jennifer, do you want to start on that question?
So, yeah, it's a great question. I think it's a great question. So for the first year ever, there will be CPT codes that reimburse for clinician education of caregivers. But the overwhelming majority of quality metrics really focus on patient outcomes, patient engagement. So I think that, and I would say that across the board, there also has been a recognition that clinician education often really is focused less on competency around engaging caregivers and care partners. But it is true that that sort of value-based payment, like global budgeting or having a salary, would afford more flexibility for really trying to meet the patient's needs, as opposed for fee-for-service medicine, where it's really trying to get patients, where the focus really is more on volume. So it's a good point. I don't know, Kate, if you want to, or Jean.
The only thing that I would add is, even in value-based care models and global payment models, these organizations are still being evaluated on a set of quality metrics, as Jennifer said, that don't include things like caregiver engagement. So still, with a limited amount of time in a visit, an organization is still going to stress, please do these things that get us to the quality metrics that we need in order to, in order to profit from being involved in these value-based programs.
And I'll just say one other thing, which is even the guide Kate mentioned early in her talk, the guide model, which is a new voluntary payment model for dementia care. And that does have it baked into it support for caregivers, including respite care. But the model is really, it has a focus on a primary caregiver, and as opposed to thinking about the fact that people with dementia often have a sort of a network of individuals who are involved. So I think there's a long way for us to go in terms of redesigning care delivery to meet the realities of how people with complex health needs manage their care.
The next question, I think this was when you first showed the pyramid, so it wasn't specific to a project, but you talked about uptake of shared access being limited, and they were wondering compared to what? Limited relative to what?
Well, it's for sure limited relative to patient portal signups. And we know, so for example, Jennifer showed that slide about looking at messages with 97% of messages that you could identify that they were from a care partner had logged in under the patient's credentials. So even though the functionality is widely available, we know that care partners are not signing up for it in the same, they're simply using the patient's credentials to log in.
Okay. And then Jennifer, the next question, you were talking about what was used to evaluate the shared access project, the different categories. Someone asked, did you not include total disease burden, i.e. comorbidities?
We did look at comorbidities. I will say that it is there was a lot of complexity of working across multiple systems, because just the way information is captured varies. So we did include measures of comorbidity, but we were not sort of looking at adjusted models. We were more trying to just characterize the population. And so that was one of the metrics that we tracked, along with age, gender, I think dementia diagnosis. But some of the measures like services use were highly variable, and it was unclear that we were not going to be able to fully reconcile services use in a comparable way across the three organizations.
The next question this was about the shared access project. Has the factor of health literacy been looked at in regards to family members? For example, are doctors' notes understood to ensure no errors are made in the patient's care? Do they have to acknowledge anything when being assigned as a proxy?
I'm happy to take that one. So no, the health literacy piece, like you are given in the language that it is written in, right? So there is a huge opportunity, I think, for us to recognize, the care teams around our patients and some of those language barriers, and as well as, education and literacy around health information, I think is huge. When you I am most familiar with MyChart's proxy access for families. Yes, there is acknowledgement of accepting a proxy access of what, like, there's on the side of the patient, there's the ability of what you're sharing. So some folks can just share billing or administrative type things, and then there's this opportunity to share the whole record. But there's not one of the things that was discussed a lot in our shared access is it's all or nothing is a very much approach of a lot of the portals, and that's one of the challenges of care partners. So I have a funny story with that too. It's just, you have to be aware if you're going to share with your parents, like, you're going to see everything in their chart, so be ready for the things that you may see. But yes, in the acceptance of it, it's acknowledging that you're getting access to that person and what they've assigned you. So hopefully that answered that, Brittany.
Oh, Deb, you're muted.
How have you partnered with health informatics professionals with your initiatives based on what you've shared here? As a health information professional, I see a lot of areas for collaboration, ways we could support each other on the research projects, and especially the AI ML perspectives.
Yes, the answer is yes. We have collaborated with health informatics folks throughout this work. So the shared access project included informaticists from each organization to be part of both the design and evaluation of the project. We, as a sort of an OpenNotes and the Shared Access Learning Collaborative, we include informaticists there are informaticists that come to the Shared Access Learning Collaborative, and we're focused specifically on working with them to go to the vendors to say, here are some things that we think could be improved. So informaticists are key to what we're doing. And if we have informaticists on the call that are interested in joining us, please reach out. Deb, I think we're at the top of the hour. I don't want to keep people longer than the hour. And I know we have some questions in the chat, in the Q&A, that are not answered yet. So what we've done in the past when this happens is, when we send out the link, the recording of the webinar, along with, I see there was a question in there about the secret shopper paper. We'll send those things out, and we will answer your questions. We'll include an answer to any unanswered questions in those documents, but also feel free to just reach out by email too if you have a burning question that didn't get answered today. Thanks so much to everyone for joining us, and be on the lookout for that email from Deb with all of the follow-up. Thank you.
Thanks, everyone.